We can go ahead and get started, I guess. Do you guys want to learn all about off-cycle residents and counting and calculations and reporting and stuff?
Yeah.
Okay. Go ahead, Megan, you can start.
Yes, my name is Megan Gudzegeski, with the webinar committee with AFMA, introducing Lisa Ann Aurora and Tiffany Ridge, who will be discussing off-cycle residents.
Thank you, Megan. Whoop, whoop. Okay, so welcome everybody. For those of you that don't know me, I'm Lisa Ann Aurora. I am the coordinator at the Chehalis Rural Training Program in Washington. And this is Miss Tiffany Ridge.
Hello, I'm the director of GME at Reed Health Residency in Richmond, Indiana.
Okay. So we're going to talk about off-cycle residents. These are our goals and objectives for today in Word format. This was also out in the blast. We put it on here so you guys can read it, but we're not going to read it to you slide by slide. But here is a roadmap to what you want to do when you have an off-cycle resident. The first thing that you're going to want to do is define the off-cycle scenario. Build your source of truth, that's spreadsheets, and then run your calculations for FTE, complement funding, board eligibility, things like that. Put together a communication plan for all of the peoples, and then monitor and close the loop. We'll go to the next slide. So why off-cycle residents matter? Because there are ripple effects that can be felt throughout the 3 years, 2 years, 1 year that you have the resident. There will be operational ripples that it would be coverage, it will be call, it can be rotation. Do you have to modify your rotations because now you have an extra person, or you missed a person and now they're gone, things like that. Faculty, communications with the sites, financials, FTE, cost reporting, hospital and clinical agreements might need to be adjusted, thinking like resident contracts, things like that. Or if you have an affiliation agreement between a hospital and a medical group, and that it requires a change in numbers and things like that, you'll have to update that. Compliance ripple effects, resident rosters, ads, reporting, board eligibility, training lengths, documentation and approvals, and then people, what's going to happen with your residents when you bring the new resident on board, or when you lose a resident, or when a resident has to extend because of a number of things. And then, how do you reduce the stress from that? And that is through communication and clarity. So we have 2 cases today that we're kind of gonna tag team through. The first one is for my program, for Chehalis. We have an off-cycle resident who started her 2nd year after we lost a 2nd-year resident. She started in March of 2025 with her anticipated graduation being March of 2027. So she's going to spend her last 2 years with us. And we worked with our APD to get our numbers and the experiences for approval for the 1st-year rotations. And then Tiffany has a resident that is off-cycle due to a visa delay and then 2 rotation failures at 2 separate times in their career. August 1st was the delay for the visa, and then the failures were in July and December of 2024. And so hers is more complicated because it started off with a delay, ended up with an extension, and then another extension. So hers is way more fun than mine. And if you have any questions while I'm going through, please stop me and ask questions, or if you have questions of Tiffany in her case, just stop. Whoops, too fast. Stop us and let us know. So the first thing you want to do is you want to define the off-cycle event that you have, because there are many different iterations. You can have a leave of absence. It could be a family leave. It could be a medical leave. It could be unpaid leave. It could be extended PTO. We don't ever fall into that one. I don't know that that extended PTO thing is very common. Mostly, I think it's going to be some kind of leave if it's going to fall into this category, family, medical, or unpaid. Also, extension / remediation milestone delays, the failures for the PEDS rotations for Tiffany's resident. So repeated rotations, obviously they failed them, they're going to have to repeat them again. Or additional assessment time. We had another off-cycle resident where she needed additional time to be able to get from a PGY1 to a PGY2 status, and that required her to extend by 6 months. Transfers in and out. So we had one resident transfer out in December, which gave us a dip in our FTE, and then we got a resident to replace them, but not until March. So now she is off from March until March. Research and individualized pathways. So that's dedicated time outside a typical block plan. I don't know many programs that do anything like that, but if you do speak up, we'd love to learn about that type. Administrative adjustment, visas. We have someone who started later this year due to visa delays. Tiffany's resident started with a visa delay. It could be licensure or an onboarding delay caused by visas or whatever, delayed start dates for whatever reason. Those would fall under administrative adjustments. And then, are there other scenarios that you might have specific to your program? Can anybody think of anything else that might fall into this scenario? If so, why don't you drop it into the chat? Or speak it out loud if you want to. Boy, this is going to be a fast webinar. Okay. All right. Well, let's do step 2 is building your source of truth. There are minimal data elements that you need to keep track of, right? Obviously, resident name, what their PGY level is, where their program is. Some programs have multiple sites. They have a core program and rural RTTs, actual training tracks. They might need to keep track of that. What was their original start date if they are extending because of failures or need for remediation? Then what is their new anticipated graduation date? What is their trigger date? So you need to know when they're going to be up for contract renewal. When does their PGY year end? Things like that. When was their leave approved? What's their extension dates? How are the rotation blocks going to be affected? For us, if we had a resident that had to redo pediatrics, there's no easy place to put them in, right? You'd have to find a rotation someplace else for them. For us, I'm not sure how Tiffany's program works, if she had to find another place for the resident to do peds, or if they have availability in theirs.
Yeah, we have to find another place as well because of the capacity or lack thereof, I guess. So we have to get other places.
Yeah.
It takes time.
And that's another thing to look into. You know, they need this, they failed it. When are you going to give it back to them? When are they going to extend? You know, you need time to find new locations, new sites, right? Things like that are all going to figure into it. How are your rotation blocks or your clinic sessions going to be affected? You know, are they going to do more clinic now that they're extending? Are they going to do less clinic now that they're extending? Are they going to do regular clinic? So our person that is extending, she didn't have continuity clinic in her first year. she still needs to meet the expected number of visits that we have at a minimum, and she has to have the right panels, and still has to get the number of hours in. So we have to build in more clinic sessions for her than we would for a normal PGY3 or 2. Board requirements. Does she meet all the board requirements? We have to make sure that, you know, our resident is only has 2 years with us, but we got to make sure that she meets everything that is required of the board, so that she can get her board certification when she graduates from our program. We got to make sure she keeps her continuity clinic status as well. And then do you need to get approvals for these changes from the PD and the CCC and the GME and the DIO and all of the offices? Our institution is lucky, or we're lucky, because our institution let us bring another resident in, and they let us extend that other resident without looking through the finances. But some programs are not.
How are we in the wrong?
Some programs need their financial institution to sign off on that. And how do you work through that? I don't know, Tiffany, is a program that you have to get approval from your institution?
I don't have to get approval unless it exceeds so many months. So I think it's 6 months if we're going off by 6 months or so.
Okay. So it looks like people were stuck in a different meeting. This PowerPoint can be sent out after the meeting, and we did record it, so it will be available once our meeting is over. The link on the invite was incorrect. Oh, that's fun. So sorry to those that had an incorrect link for the webinar. Thank you to everybody that has showed up since they got the correct link. And the thing, we're only on step 2 of 5, so.
And we'll also share this on YouTube.
Yeah. So we've gone through minimal data elements. The next is training timeline. You want to make sure that you track dates, when they're supposed to progress to the next year, because they're not progressing with the regular class. What impact is that going to have on graduation? So our resident, even though we have 2, one that doesn't graduate till December and one that doesn't graduate till March of next year, but they still marched with their PGY3 class, which was this year in June, which is a little weird. We've never had someone quite so far off March, but we're not going to ask them to come back after they graduated. But I mean, every program is different. Do you allow them to march or not? Do you give them their diplomas in June, or do you hold on to them and make sure that they actually get through all of their stuff before you give it to them? You got to look at schedule impacts, like I said before, rotation, call, clinic templates, coverage. Like I said, my one resident, she had to hit the ground running, and she had to ramp up way faster than her other residents did, because she's still got to meet those requirements for hours, for number of patients, so that she can be competent. Get her patient panel had to be up and running higher than normal for someone that was just coming into our program as well. Compliance impact. You're going to have more residents than you're officially approved for on ads. So you have to get a temporary increase in residents. Board eligibility, institutional reporting, all of these things need to be taken a look at before you bring that resident on board. And again, I've said it before, I say it again, financial impacts. Are you going to have more residents in than you would normally would? Are you going to pay their salary or not? I mean, obviously you are. And if not, you're going to have to let them go, things like that. And cost reporting, the fun IRIS stuff. That's always fun. Yay. Okay. Are there any questions so far? Next is calculating. What dates count towards their 36 months? What time must be made up? Complement. Does the temporary change exceed approval complement and require ads workflow? So do you have to go into ads and request a temporary increase? Like I said, graduation, does something need to be adjusted, or are they allowed to graduate in with your regular graduation class? Continuity clinics, you got to make sure that they still maintain their continuity. They still have to have the 40 weeks. What do you count as the 40 weeks? If they're extending for 6 months, well, that's obviously, there's going to be 40 weeks in there, but then when do you start their PGY2 year? Is that 6 months just a bonus? FTE funding, you got to make sure that your FTEs count. IRIS records for finance, schedule coverage, which blocks are going to be covered or shifted. If you're pulling them off a rotation because they failed a rotation, which rotations are you going to pull them off of? If you pull them off something like another inpatient service, are you going to have to get someone to cover that service? It all depends on what your hospital has, but these are all things that you need to think about when you have off-cycle residents. And do you have commitments to any sites? Like, are you pulling them from a site that you said that you will always have a resident there? Then who is going to cover for that? This can get very complicated. So calculations. So these are my spreadsheets that I use for calculating my off-cycle residents. We do our calculations for ambulatory and inpatient every month. I know Tiffany does her ambulatory counts every week. I think.
Mm-hmm.
But you have to know like what counts in what year. So my resident, she started in March. So she is actually going to go from March of one year through February of another, March to February, so that these are her actual PGY years, right? So she's not July to June like everybody else. And you got to make sure that if you have formulas counting for academic years, that they count the proper months in that year. Otherwise, all of your counts will be off, especially things that you report out to the ACGME. Also, for like inpatient numbers, there are things that you have to count, right? So just a little note down here for my inpatient numbers, you can see that we counted things from her first year, her EM visits, her adult and ICU visits from her first year, some more EM visits, some more. So these are adult ED patient. Oops. These are all in these 3 slides here. We allowed those to come in from her first year. We counted those as experiences that met with the family medicine requirements. And then what we have for our CCC, we have a summary report for all of our residents. And so this information that's here is actually summarized right here. As you can see in the R1 year, she doesn't have anything, but the counts are counted here in the R2 year. And then her R3 counts will be in this row down here. And then the total counts are up here. And then obviously her continuity clinic numbers, her percentages throughout the residency, her panel counts, and her provider perspective and patient perspective visits, which are also things that we have to report out to ads. Any questions so far? I know this is so much fun. This is the ton fun stuff.
Lisa Ann, someone did ask in the chat if it's possible for you to share your Excel sheets. I'm not sure.
Yeah, yes, definitely. I have these templated so I can send these to you. And for the ambulatory numbers and the inpatient numbers, each graduation year has its own tab, and that just follows them through the entire 3 years. And then for ambulatory, I have a summary tab so that we can see how they're doing throughout the 3 years as well. I did not include that summary on this page. But yeah, oops, hello. Sorry, I didn't realize that I was moving that fast. Okay, so for family medicine lens, so stuff that's important to family medicine as a whole, right? The ABFM, there are specific requirements that you have to follow through. So candidates are required to complete 36 months of GME in family medicine. Now, obviously, residents can transfer in as a second year. When they transfer in, you have to let the ABFM know that you're giving them a year of credit towards their family medicine board certification. And it doesn't have to be a year. It could be 3 months if what they went into was like surgery and they did a year of surgery. Obviously, that doesn't count towards, family medicine because the requirements are different. Some situations, example, surgery to family medicine might require them to extend their training. And the program director still has to verify their readiness and that they met all requirements through the RTMS. Is there a question? Okay. Continuity requirements, ABFM, as we know, has 40 continuity weeks every year, and that they must complete 1,000 hours of care for the family medicine site. So you have to look at that as well. And then leave planning, you got to make sure that they still meet all the leave requirements. So if they were on an extended leave of absence, obviously they're going to have to make up time, things like that. Okay. So complement and adds, and this is true when things get complicated. So these are questions that you have to ask yourself when you're putting together this resident. Does the change affect the total approved complement? If it does, then you're going to have to get an approval for a temporary increase. Is the change short-term or long-term? You have to look that up. Is a DIO approval required before the request can move forward? Then documentation that you want to keep. If a resident is transferring in, you got to make sure you get resident-specific rationale and training plans, block schedules from when they were transferring in, but you also need to put together a training plan for your resident if they're extending for any reason. Faculty resources. Is this going to require more faculty resources? For example, Tiffany's is on a remediation, might be on a remediation plan, correct? So that requires more faculty input.
Yes. Yes, our off-cycle resident, we had basically a faculty member took a whole month of remediation and individualized learning plan to prepare them to retake the particular rotation. So that did take some extra faculty resources.
Thank you. There is a question in the chat. It says, what are the steps to getting temporary increase to your complement? You just reach out to the ACGME. You do go on to web ads and you can request a temporary increase, and you have to put the rationale in there for that increase or the reason why. Yeah, and you just do it through ads, and then it goes to the PD, sends it in, the DIO approves it, and then we get approval through the RRC.
Is it a relatively quick process?
I believe so.
My experience has been that it's fairly quick turnaround. But you don't have to request if it's less than 90 days. If the complement increase is less than 90 days, then you don't have to request that from ACGME.
I see. Thank you.
And you can always go on to the web ads to see if your complement is correct.
Mm-hmm.
Shantae, were you going to say
I have a
something?
question. Yes, ma'am. Shantae, how are you?
I'm fine, thank you. How are you?
Good. I have a question. So I have my very first MD, and he failed boards, and so I don't know if this is the right topic. Maybe I shouldn't. Anyway, on the residency management system,
RTMS, yeah.
since I didn't promote him to PGY1 because he didn't pass his boards, how do I adjust his date in there to be able to, because I'm assuming that means he'll be off cycle, correct?
Yeah, if you require that they pass their boards before they can matriculate to a PGY2 or from a PGY2 to a PGY3, then yes, you will have to go in there and he will have to be extended for as long as it takes for him to pass, if that's what you're doing. So some programs say that they can't take the boards more than twice. Ours is twice, so, or not boards, the steps, the USMLEs. So they're allowed to fail once, but they must pass on the second attempt. And if they don't, then that's failure, and then they are released from the program. So you have to decide.
I need to guess, like, estimate how long it's going to take, like when he takes the exam and how long it's taking for results. And then that's the date that I put for the extension. Is that correct?
Yeah, I would talk with your, our APD and I usually work on things like that together to decide, okay, well, the next time that he can take it is this date. That means that we should have an answer by this date. So it looks like until that time, he's going to be on this remediation plan until this time, and then he won't be able to matriculate. The other thing you'll have to do is he'll have to have an extension done to his whatever level he is. If he's a PGY1, he has to have an extension to his PGY1 contract showing until whatever date you put in there. Things like that. Yeah.
Yeah, I was just wondering, since I've never dealt with that system before,
Yeah.
in there, I just didn't know the process on that.
Yeah.
If that would affect him later.
It might, yeah, because is he on a remediation plan right now? Because he failed?
Yeah, he's on a plan right now.
Yeah. So that'll affect him later on down the line, but I guess if he gets through it, it's a good thing.
Yeah. Okay. All right. Thank you.
You're welcome. And then approval pathways to increase your complement. The program obviously has to review it, right? We do that every day. The PD and the CCC have to make a decision. The GME office and the DIO, you generally have to get approval for a complement increase. That's what you should be talking about at your GMEC meetings if you are anticipating that you're going to be extending a resident or bringing in a new resident because you lost one, things like that. Your finance HR department are going to need to know that you're bringing in a new person, obviously, because they'll have to onboard them and all of that stuff. And then you need to make sure that you close all the loops. You got to close everything. You got to make sure everybody knows what the decision is and how long and all that fun stuff. But you can use this here to help you answer some of these questions and work through the workflow. You can use this as a simple yes, no, like, does the change affect the total approved complement? Yes. What does that mean? What do you do? Is it an temporary increase, or are you getting a permanent increase because you decided, yeah, you really do need 4 residents in the 3rd year? I don't know. Things like that. Next is FTE funding. So what do you have to look at when you're looking at funding an FTE? Are you going to have more full-time FTE? Are you going to have partial FTE? What is your time period for the increase? Which academic years is it gonna affect? Which rotations is it gonna affect? Which pay periods is it gonna affect? Which locations too? Is it in the hospital? Is it in the continuity clinic? Is it somewhere outside the hospital in another rotation site? How much is going to be countable? So if you are already at a set cap, which most programs are for FTE for the CMS, you're going to be above, more than likely, the FTE allowed. Is your hospital okay with that? That means they're eating the cost of that resident. Are you going to allow them leave time? Generally, you're going to have to. You know, are they going to have to make up time? What is going to be considered non-countable time? That's the above over your cap for FTE. What kind of support are you going to need? Are they going to need, you're going to have the extra salary? Is there going to be extra training costs for the resident? Like, you're going to have to buy more BLS books, or, you know, whatever. All those little things count. And then you got to make sure that they're still in the cost reporting. And then you got to reconcile. You want to reconcile your resident roster with your schedule, with your payroll, with your finance worksheet, your leave tracker. You got to make sure that they are included in all of these sheets that you have and you keep track of. And then you can, you know, do all the fun things. This is a template. So if you have a thing that you think is coming up, like Shantae, so you could use this as a what to walk through for your resident that might be extending because of failures. So these are just a way for you to easily put this information in and get some kind of decision at the end of it. So we just put this in here as a help. You're welcome. See, we knew you were coming, Shantae. We put this in here just for you.
Oh, thank you.
And then, so here's your workflow from identifying that you're going to have an off-cycle resident all the way through to auditing to make sure everything is accounted for. You want to identify what the new dates are. You want to determine the training continuity, schedule, funding impacts. You want to run all those formulas on all those spreadsheets to make sure everything is correct so that you're not giving them wrong information for their training years, especially since you're going to be reporting that training information to ads and ABFM. You want to make sure that the off-cycle resident approval goes through the correct routes. You know, the PD, the CCC, say it again, the GMAC, finances through the hospital. You want to make sure everything is updated. Ads, again, ABFM, so the RTMS, updating that, and any of the rosters that might be running around your hospital. You also want to make sure the residents are informed. Are they aware that there's going to be an extra resident? You don't, obviously, if it's somebody that is on a remediation plan, you're not going to go tell the whole world, right? But you have to let them know basics, like this resident is going to be extending for whatever reason. It's a hard line to walk, and a lot of times we walk it for more confidentiality as opposed to less in our program, and sometimes that makes residents feel blindsided when a resident winds up all of a sudden they're extending, but it's because we keep confidentiality so close to the vest for our residents to protect them. And that's a hard line to walk too. I don't know, Tiffany, if you have any tips on how to do that well.
I don't know about well, but we do try to maintain the highest level of confidentiality surrounding those extensions. And but to be honest, generally when there are issues amongst residents, residents know about it, not and they don't have to know about it from us. So people are pretty respectful for the most part, at least have been in our program. But yeah, we try to maintain confidentiality, but at the same time, so it does impact different rotations and different teams, and so they need to know what's happening.
Especially if they're on a remediation plan and they're not just off cycle because they came in.
Yeah.
And that's usually part of the remediation plan, is letting the groups know that they're going to be affected by it. And then again, make sure you close that loop. We do our spreadsheets monthly with all of our numbers so that we make sure that the off-cycle residents are meeting their requirements and that they will be able to graduate with what they need to become board certified and to pass the ads, ACGME stuff. Okay, this is another tracker that we put on here. These columns obviously are intentionally broad because programs are not cookie cutter, right? My program is different than Tiffany, is different than Megan's, which is different than Shantae's, right? Everybody's program is a little bit different, but these are the main broad categories: the resident, what the triggering was, why, what the dates are, how is the training impacted, what's the continuity going to look like, FTE funding, owner, and status. I will say it is always good to have one person in charge of spreadsheets and the owner and the know, because if you get too many hands in the pot, something generally falls through the cracks. I see Faye shaking her head yes. Tiffany shaking her head yes.
Yeah.
Yeah.
Formulas disappear or miscount, and yes.
Yeah. Exactly. But this is just a sample, another sample for you guys, another way for you guys to track things. And like I said, I can send that spreadsheet out to everybody. Faye?
Quick question. Do you add this like tracking into like the executive minutes on residents, like those confidential minutes when you're doing check-ins, or is this a separate thing that you do?
I would say this would be a separate thing, but
Okay.
maybe it would be a good place to put it in the executive minutes for the residents when you're talking about them, just so you have everything that's there. Generally, this would be, I think, we would use this type of field for like me, the APD, the PD, and maybe the advisor of the resident, so that everybody's on board with the way everything's going.
Thanks.
So you also have to have a communication plan. Like I said, keeping things close to the vest. You got to let the resident know, not just the resident that's affected, but you have to at some point let the other residents know, because they are going to be affected as well. That doesn't mean you tell them what's going on, obviously, but they need to know that a resident will be extending, what the graduation implications are, etc. Faculty rotation sites, faculty that are going to be affected, rotation sites that are going to be affected, they need to know the plan. Finance, HR, they need to know if you need to have an addendum to a contract for a resident saying that their PGY2 year is now going to end on September 30th instead of July 30th. Program leadership obviously needs to know, because of all of the things, right? Your GME office, if you have one, needs to know. If you're the GME office, then you obviously know already. There are some of us that don't have a GME office. And then the boards, you need to make sure the ABFM and the ACGME knows. And you need to make sure that your residency management platform has the new dates for the residents as well, because otherwise they'll be changing when they're not supposed to. And I think, so here are some pitfalls. Only updating the master schedule and not everything. Using the academic year for one calculation and cost reporting for another. You got to make sure that everything is consistent across the board. Assuming leave automatically means extension. It doesn't, because the ABFM allows for 20 weeks of leave. So they might not need to extend, but they might still be off cycle in it, or they might not off cycle, but they might need to make up rotations that are missed due to a leave, things like that. So this says no single owner, but yes, that's a pitfall. You want to assign one person, like I said earlier, to make sure that all of these things are in the right place. And then you don't want the day before a resident shows up at a site and they've failed, PEDS twice and say, oh, by the way, this is their third time through, just so you know, we're sending them to you because they failed 2 other places. You might want to give them a little bit of lead time in knowing that the resident is coming through is on a remediation plan. Stephanie, do you have any other words of wisdom to add to this?
No. No, you think you've covered it. Yeah.
And then that is it. Thank you all for listening to me ramble on about all the fun things of off-cycle residents. Does anybody have any questions? And we'd love to see faces. And these are our email addresses if you want to reach out to us with any questions if you don't have any right now. Do you mean to alert rotation sites that are not related to the resident? No, we do not alert sites that are not associated with the remediation plan. So for example, if a resident is remediating pediatrics, only PED sites that are part of that remediation plan will be notified. We wouldn't let medicine or OB know because they've passed those. It has nothing to do with their pediatrics rotations. And you guys can ask questions out loud too. You don't just have to type it in the chat. We like to hear other voices other than mine. Please and thank you. So
oh, go ahead.
Rhonda, yes, because that's all you have right now. Because remember, ads only wants the information that's within the academic year that we're looking at. So then what I have done with my off-cycle residents are their PGY1 information is up until whatever time frame that year ends, so June 30th. And then the following year, I will revisit the numbers for the PGY1 year, and then I will add into the PGY2 the numbers that we have so far. And then the following year, I will update the PGY2 numbers so that they are all complete, and then add the PGY3 numbers through whatever. So for my resident that started in March, our first ads only had from March to June of her. So it only had like 3 months of information. But this year, when I go to put her in, I'm going to have March to February, and then I will have March to June. So I will be updating 2 fields for her instead of just 1 like everybody else. Does that make sense?
Yes, thank you.
You're welcome.
Does anyone else have any questions for Lisa Ann or Tiffany? Otherwise, we will end this webinar. Lisa Ann will send the presentation through the AFMA listserv. Is that correct, Lisa Ann, along with your Excel sheets?
Yes, I can do that.
Okay. And then we will also put this webinar recording on our YouTube channel. Have a great day, everyone.
Thank you for showing up.
Thanks.